Welcome. In this video, we'll explore how interpersonal violence impacts pregnant and birthing survivors, and how advocates can provide meaningful, trauma-informed support. We'll connect abuse dynamics directly to pregnancy, labor and birth, and postpartum experiences while centering the unique realities of Black, Indigenous, LGBTQ+, disabled, Latina, Hispanic, MENA, or Middle East and North African, and AAPI, or Asian American and Pacific Islander survivors. Pregnancy is a critical window. 1 in 6 survivors first experience violence during pregnancy. Domestic violence is linked to miscarriage, preterm labor, and even maternal death. These risks are magnified by systemic inequities. Black women are 3 to 4 times more likely to die from pregnancy-related causes, often because their pain is dismissed or ignored. Indigenous survivors face the highest domestic violence prevalence rates in the United States and higher maternal mortality from delayed or denied care. LGBTQ+ survivors experience reproductive coercion and healthcare bias, especially around fertility, birth plans, or postpartum recognition of partners. Disabled survivors may have abusers control their access to doctors or adaptive equipment. Latina and MENA survivors may fear deportation or cultural stigma when seeking care. AAPI survivors may avoid disclosure due to shame or language barriers. During pregnancy, abuse often looks like reproductive coercion, forcing a pregnancy, or pressuring abortion. Partners may block prenatal appointments or withhold money for care. For example, Black and Indigenous survivors may be told they're exaggerating their symptoms and discouraged from seeking care. This echoes racial bias in healthcare. LGBTQ+ survivors may be pressured into a pregnancy that doesn't reflect their family goals. Disabled survivors may have their mobility or transportation controlled, making prenatal care dependent on the abuser. Latina, MENA, and AAPI survivors may face isolation when partners forbid them from using their first language with providers or refuse to translate accurately, limiting autonomy. Labor and birth may also become sites for abuse. Some survivors report partners delaying hospital transport, mocking them in labor, or forcing medical decisions. After birth, abusers may withhold the baby or sabotage breastfeeding. These dynamics intersect with identity. Black and Indigenous survivors are more likely to have pain dismissed or interventions forced without consent. LGBTQ+ and trans survivors often face misgendering and exclusion of their partners in delivery rooms. Disabled survivors may have equipment needs ignored or medical consent bypassed. Immigrant survivors may be left at home in labor if their partners feel hospitals, while AAPI survivors may face pressure to follow traditional practices enforced by the abuser against their will. Some shelter policies may also re-traumatize survivors. Imagine a new mother recovering from a C-section being punished for missing chores, or a postpartum survivor needing food at night but denied access. For Black and Indigenous survivors, already overrepresented in child welfare systems, strict parenting rules increase fear of removal. LGBTQ+ survivors may fear being judged as unfit. Immigrant and MENA survivors may avoid shelter altogether if they worry about immigration enforcement. Disabled survivors may be penalized for needing more rest or needing adaptive equipment. Too often, the pain or symptoms of survivors are dismissed, or their disclosures are ignored. As mentioned earlier, Black and Indigenous survivors are less likely to have their pain taken seriously. LGBTQ+ survivors may be misgendered or denied partner involvement. Disabled survivors report doctors speaking to abusers instead of to them. Latina, MENA, and AAPI survivors may face language barriers when interpreters are withheld or abusers are used to translate for them. These dynamics echo coercive control. Some tools for advocates include offering to accompany survivors to appointments if they find that supportive. Request patient rights, maybe a support person being present or an interpreter provided. Help survivors prepare questions in advance, perhaps role-play disclosure and self-advocacy if the survivor requests that. We know that systems themselves can often cause harm. Black and Indigenous survivors are more frequently reported to child welfare, even for minor parenting issues. Courts may side with abusers in custody battles, especially if survivors are LGBTQ+ or disabled. Immigration fears are weaponized against Latina and MENA survivors. Police may dismiss reports of domestic violence or escalate violence against survivors of color. Tools for advocates include accompanying survivors to court or child welfare meetings if they request that, providing letters of support that highlight survivor strengths, connecting survivors with culturally specific or legal advocacy organizations, offering safety planning that accounts for systemic risks, for example, ICE raids or child welfare bias. These harmful practices replicate the same coercive control survivors experience from abusers. Survivors may avoid shelters, hospitals, or agencies entirely if they fear punishment, bias, or surveillance. For marginalized survivors, these barriers are compounded by racism, homophobia, ableism, and xenophobia, deepening isolation and mistrust. Advocates have the power to disrupt harm. In healthcare, you can accompany survivors and request interpreters. In agencies, you can challenge gatekeeping and advocate for inclusive practices. With all systems, you can accompany survivors to court, write support letters, and safety plan around risks of child welfare or immigration enforcement. Your role is both supportive and systemic, reminding survivors that they deserve safety and dignity in every space. To summarize what we've learned in this short video, domestic violence often escalates during pregnancy, labor, and in the postpartum period. Shelter rules can re-traumatize survivors. Equity and flexibility reduce harm, and advocates play a vital role in restoring dignity and safety for survivors across all identities. Every survivor deserves healing, safety, and dignity before, during, and after birth. Have local and national resources ready. Michigan's sexual assault, domestic violence, and human trafficking hotline is 1-855-VOICES-4. Partner with community organizations that support survivors. Your shelter can become a safe entry point to healing and services related to pregnancy, birth, and parenting. Thank you for taking the time to watch this short video on trauma-informed ways of supporting pregnant, birthing, and postpartum survivors. You can learn more about this and related topics at www.mcedsv.org. Click on the Maternal Health heading to access a wide variety of other recorded trainings, information of upcoming live trainings, and hundreds of other resources. This video was developed with support from a grant from the Michigan Department of Health and Human Services Maternal Mortality Surveillance Program. The opinions, findings, and conclusions or recommendations expressed in this training are those of the Michigan Coalition to End Domestic and Sexual Violence and do not necessarily reflect the views of the U.S. Department of Justice or the Michigan Department of Health and Human Services.